Hello, and a very good afternoon to all our viewers to this brand new session of Dentessentials, where today we'll be talking about a very commonly encountered problem in dental practice, which is endoperiolesions and their management. Endodontic-periodontic lesions, or endoperiolesions as they're commonly called, are tooth anomalies that involve the pulp and periodontal tissues of the same tooth. A single lesion may present with signs related to both types of presentation, thus making it difficult to diagnose and often necessitating interdisciplinary management approach. Therefore, it is imperative that dental surgeons be thorough with the diagnosis and management protocols for endoperiole lesions. To discuss more about endoperiole lesions and their management, we have with us today Dr. Aastha Shukla. Dr. Aastha Shukla has done her master's in conservative dentistry and endodontics. She is a member of IACDE, which is the Indian Association of Conservative Dentistry and Endodontics, and she has numerous publications to her credit, along with a book published on imaging and endodontics. She's also an assistant professor at Modern Dental College and Research Center, Indore. She's a consultant endodontist and aesthetic dentist and runs her private practice at Shukla's Dental Clinic, Indore. It's an honor to have you with us today, Dr. Shukla. You may please share your screen and begin your presentation.
Thank you, Manisha, for this beautiful introduction, and a very good afternoon to all the doctors, those who are present here. I know it's a post-lunch session, so I won't delay the presentation and will directly come on to the topic. Also, I would like to thank Doplexus for giving me this opportunity so that I can share a little bit of knowledge what I have on endodontic-periodontal lesion and its management. Now, why I chose this topic is one thing which is very important, because many times we see a very good endodontically treated tooth is having a lesion, or a very poorly treated endodontically treated tooth will not have any lesion and surviving for years. And also there are times that a very good endodontically treated teeth obviously will have a lesion, and then again they'll call the consultant and will ask to repeat the root canal treatment, which is again very irritating without knowing the cause. If we keep repeating the endo or we keep repeating the treatment and still there is no good result, then it is not good on the patient's part as well as not good on the doctor's part as well. So that is why here I have chosen endodontic periodontal lesions. A briefly what all we can cover in this topic. There will be introduction, because without introduction we won't be able to continue. Pathways that are connecting endodontic and periodontal tissues, etiological factors and contributing factors. What are the factors that are responsible for initiating endoperiole lesion? What are the factors that are responsible for progressing of the lesion? Sorry. Definition, of course, maybe it looks theoretical, but it is important. Classification, diagnosing, how will you diagnose different endoperiole lesions? Definitely treatment and conclusion and references, because without references we do not know what science is. First, we'll have a short history, because without history there won't be any present. So in 1919, Turner and Drew first described the effect of periodontal lesions or diseases on the pulp. The relationship between periodontium and the pulp was first described by Simring and Goldberg in 1964, around 40 years later. Since then, the term endoperiole lesion has been used to describe lesions that are due to inflammatory products, maybe because of varying degrees, maybe less inflamed or more inflamed in both pulpal and periodontal tissues. Also, we know, and also we have seen many studies that they are responsible for 50% of tooth mortality. The pulp and periodontal tissues, they are so commonly associated that they have embryonic connections, ectomesenchymal cells, and anatomic connections by dentinal tubules, lateral or accessory canals, and functional interrelationship. Then, what are the pathways that are connecting endodontic and periodontal tissues? They are so closely connected, but there are still a few barriers or few things that are connecting them. They can be divided into anatomical pathways and non-physiological pathways. Anatomical pathways will definitely have apical foramen, and then accessory canals or lateral canals, which are having our connective tissue and vascular lymphatic drainage. Congenital absence of cementum exposing dentinal tubules. This is very rare, but is seen in cleidocranial dysplasia. Developmental grooves such as paratogingival grooves. Also, they are very common in lateral incisors and central incisors. They are more common in lateral than central incisors, and they extend from cingulum to the depth to the apical third. or middle third. In 0.5% of cases, they have been reported till the apical third. There are non-physiologic pathways that will include your iatrogenic root canal perforations. See, root canal perforations, now we know they can be because of us, iatrogenic, or because of any cavity or over preparation, or where you have a strong lateral and accessory canals. That way also you can have. Also with the perforations, there is this thing that the more apical is the perforation, and maybe it is a different thing, but more apically a perforation is present, more better its prognosis is. More cervical or more in the middle third the perforation is, the poorer the prognosis is, because then the gingival sulcus will keep descending downwards and will poor the prognosis. Vertical root fractures caused by trauma from occlusion, or there are pathways that are created because of resorption and different pathways. Now coming to etiological factors and contributing factors, what is it that is causing endoperioral lesions? So that way we have etiological factors. Definitely we know there are living pathogens and non-living pathogens. Living pathogens, there are bacteria, there are fungi, there are viruses which are responsible for causing, and there are too many common bacteria and too many common microflora that is present in periodontal and pulpal tissue. Now there are non-living pathogens as well, and there are some extrinsic and intrinsic agents. Extrinsic agents as in what is outside the tooth, that is dentine and cementum chips, or our restorative filling such as amalgam or any other filling, maybe for example glass ionomer cement, or root canal filling material, absorbent paper points, retraction cord for maybe the threads, or anything other than calculus like deposits. Other things are cholesterol rich in hyaline bodies, Russell bodies, and other things. Now what are the these are the factors that will initiate the process, and there are other factors which will help the process. If these factors are present, they'll help us to progress the disease, which will include if you have done poor endodontic treatment, that will be over obturated, under obturated fillings. Maybe you do not have done, as important is apical seal, equally important is our coronal seal. You cannot keep any end open. Maybe trauma from occlusion, root resorption, internal or external root resorption for any reason, perforations that we have seen already done by any factor, because of any factor, developmental malformations like palatogingival groove or any other formations, cracked tooth syndrome, crazed lines, vertical fractures, any sort of fractures. We have studies. Without studies, there are nothing that can be judged or that can be studied as well. Murray in 1987 and Sundquist in 1994 have studied, and they have found that infected root canals have the same, infected root canals can be present with the periodontal pocket. Someone who wrote et al. In 2000, he also found that the organisms that are present in endodontic infections are equally present in periodontal infections or pockets. While Didelsky, AC et al. In 2012 found certain organisms and they play a role in pathogenesis of endoperial lesions. So these are the studies that are always important, and there should be always a line should always be supported by different studies, because otherwise we cannot just prove anything. Now there is a beautiful definition given by K. Gulabiwala, Endodontics in 2004. He described, or he defined, the endoperial lesion as it includes an isolated, usually narrow, isolated, it is not generalized. It will be confined to a tooth or two teeth if they are at all connected. An isolated, usually narrow, with a deep probing depth of pulpal or periodontal origin. This probing depth is again very important, isolated and usually narrow. This will also what will differentiate a pulpal origin or a periodontal origin. Periodontal origin is usually generalized, while pulpal origin is not, is usually localized. Deep periprobing depth, because if it is endoperial lesion, if it is not truly endo lesion, then also it will have a probing depth. So an isolated, usually narrow, deep probing depth of pulpal or periodontal origin. Then lesion with submarginal or intrabony periradicular bone loss of pulpal and or periodontal origin that communicated with the oral cavity via probing defect that we have seen already. A localized periodontal probing depth of pulpal or periodontal origin. That is a definition given by Gulabiwala. Now, as it seems to be theoretical, but no classifications of endoperial lesions are not at all that it is just useful for theory classes, but it is also what will help you in diagnosing, in treatment, in managing if there is any comeback of the case, recurrence of the case, in managing the prognosis of the tooth. So that is how a classification of endoperioral lesions are important. We'll see few of them, not all of them, one by one. Based on etiology, diagnosis, treatment, and prognosis, Simon in 1972 described and given us 5 classes. As the name suggests, primary endodontic lesions. Second one is primary endodontic lesion with secondary periodontal involvement. Third is primary periodontal lesions. Then is primary periodontal with secondary endo involvement and true combined lesions. Now, this 5th class was then omitted by Stock in 1988. And he said class 2 and class 4 lesions can be given and class 5th can be omitted. They'll give a combined lesion. So class 5 was omitted by Stock in 1988. Third classification is by Wiens, and he gave us 4 classes. Class 1, tooth in which symptoms clinically and radiographically simulate periodontal disease, but are in fact due to pulpal inflammation and or necrosis. Class 2, that has both pulpal or periapical diseases and periodontal diseases. Class 3, tooth that has no pulpal problem, but requires endodontic therapy plus root amputation to gain periodontal healing. This class is as such that we see there is a furcation involvement, a furcation radiolucency that is leading to root resorption of one case, but there is no cavity or no old filling that is seen. So that is class 3. Class 4, that is tooth that has clinically and radiographically simulates pulpal or periapical disease, but in fact has periodontal disease. These are very interesting classes. Sometimes these lesions and these classifications are confusing when we are diagnosing, but also they will help us to diagnose and manage the case treatment wise. Based on treatment plan, Grossman has classified and given us 3 classes. One that is requiring endo treatment only, second that is requiring periodontal treatment, and third that is definitely requiring both of the treatments. And the last one is classification as recommended by a World Workshop for Classification of Periodontal Disease in 1999 as endoperio lesion, perioendo lesion, and combined lesion. If it is primary endo, then endodontic-periodontal. If it is primary perio, secondary endo, then periodontic-endodontic lesions, periodontal endodontic lesions. If it is a concomitant lesions, if they are progressing separately, then it will be a combined lesion. Now coming to a very important part, that is also it is important clinically, how will you diagnose the procedures and how will you diagnose endoperio lesions. So the basic diagnostic procedures will be basic that we have been learning since our 3rd year. The clinical history, the probing, the percussion, the tenderness, and if there is any radiographic examination, if there is any sinus tract, then tracing of the sinus, and any other palpatory attachments if they are present, if we are palpating on the attached gingiva or otherwise, then all of it should be seen. Now coming to the examination or test, first will be of course chief complaint. The second thing will be, we'll see with our instruments what all is present or what all is present clinically. So we'll just describe, this is a chart where I have tried so that we can justify primary endo, primary perio, primary endodontic or periodontal lesions or combined lesions. So visually, what we'll see in primary endodontic lesions, there will be soft tissue में sinus opening will be present. In primary periodontal lesions, inflamed gingiva, obviously it will affect the periodontium definitely. So it will have inflamed gingiva or recession with multiple teeth. In primary endodontic and secondary periodontal lesions, of course, plaque will be formed at gingival margin or the sinus tract will also be present, which will lead to the inflammation of the marginal gingiva. In primary perio and secondary endodontic lesions, plaque, subgingival calculus, because it is primary perio, so subgingival calculus and multiple teeth definitely will be what will be involved. Pus, exudate, and otherwise things will be present. In true combined lesions, all of this will be present. Plaque, calculus, and periodontitis will be present in varying degrees. Also with primary endodontic lesions, we'll be able to see there will be any pulp involving things such as tooth decay, large restorations, fractured tooth restorations, erosions, abrasions, cracks, otherwise too many things. With primary periodontal lesions, swelling might be present, might not be present. With periodontal abscess, in primary endo and secondary perio, there will be exudate or pus coming from the gingival margin. Root perforation or fractures will be present. In primary perio and secondary endo, localized and generalized recession or exposure of the root will be present. And in true combined lesions, of course, pus, exudate, and swelling around single or multiple teeth will be present. Now coming to the examination tests. Of course, we'll have a history of pain from the patient and signs and symptoms otherwise. In primary endodontic lesions, definitely the pain is going to be very sharp, pricking or throbbing maybe. In primary periodontal lesion, the type of pain is usually dull and it is usually continuous. And it is sharp only in acute conditions or if there is any acute exacerbation of chronic condition. In primary endodontic and secondary periodontal conditions, the pain is usually sharp because it is primary endodontic, and it is dull or aching in chronic conditions. In primary periodontal and secondary endodontic, the pain will be primarily of dull type. It will be acute only in the cases of periodontal abscess or if there is any acute exacerbation. In true combined lesions, there will be dull ache, usually in acute conditions. It is severe. Now coming to the palpations. Palpation we usually do with our fingers. We have our gloved fingers, our gloved hands. It will palpate the area around the tooth or wherever the patient is feeling the pain. Usually in endodontic lesions, in primary endodontic lesion, it does not indicate any inflammatory process. Usually it is not that much tender on palpation. In primary periodontal lesions, there will be pain. Definitely patient will be, he is experiencing something. In primary endo, secondary perio, there will be anywhere their perio is involved and you're palpating it, in all of the conditions, there will be pain. Coming to the percussion, we all know how to percuss with the opposite end of the mouth mirror or probe and with the gentle taps. So with primary endodontic lesion, definitely it will be tender on vertical percussion, while with the periodontal lesions, it is tender on horizontal percussions. With all of them, the same will be the condition. Now coming to mobility, again, we know how to check for the mobility. With the opposite end of the mouth mirror and one of our finger, we try to move the tooth. If it is moving, then obviously there will be mobility. We all know there are grades of mobility. That is how we'll just realize, or that is how we'll just check how the mobility is. Fracture roots in primary endodontic lesion. Fracture roots and recently traumatized teeth will be present with mobility. Otherwise, there will be no mobility. In primary periodontal lesions, it will be mobile, maybe to grade 1 or grade 2, localized to generalized mobility of teeth. Primary endodontic and secondary periodontal lesions will have localized mobility. Primary periodontal and secondary endodontic will have generalized mobility, and true combined lesions will again have generalized mobility, but the higher grade will be present in where there are involvement of endodontic lesions. Pulp vitality tests, we all know there is electrical pulp testing, or there could be cold test or thermal test can be also be done. With the primary endodontic lesion, there will be lingering response. Maybe it will respond early, or in cases of necrotic pulp, it will not respond at all. Then in primary periodontal lesion, the pulp is usually vital, so it is positive. In primary endodontic and secondary periodontal lesions, if it is primary, that means the disease has progressed from the apical foramina to the periodontium. Your pulp has almost died, or usually died, almost died in cases of multi-rooted teeth, and usually dies in cases of single-rooted teeth. So it is usually negative. In primary periodontal and secondary endodontic, you might get positive, you might not get positive, but it will all depend on the multi-rooted teeth or single-rooted teeth. In true combined lesions, it is usually non-vital, so usually it is negative. Pocket probing is usually checked with Williams periodontal probe. With primary endodontic lesion, there is a deep, narrow, solitary pocket present, and that should be checked. Sometimes it is skipped via or while doing endodontically treatment, or whenever we have, sometimes we do not see if a crown is ill-fitted and it was leading to the periapical lesions, and we keep repeating endo and we keep doing it through the crown, but it does not lead to any success of the treatment. Maybe the treatment will last for 6 months or a year, but it is not justified treatment. Then primary periodontal lesions will have multiple wide and deep pockets because it is generalized. Primary endo and secondary perio will have again a presence of solitary wide pocket. Then again same primary periodontal and secondary endodontic, presence of multiple wide and deep periodontal pockets, and true combined lesions will have a combination. Sinus tracing is what is very important when you see a sinus tract. It is, the test is as easy as it can said to be. You just have to take a katta parcha, you have to embed it into the sinus tract, let it go as much as it is going in, and take a radiograph and see where that the end of the katta parcha is. Also, the angulation of the radiograph matters in this case. In primary endodontic lesion, the katta parcha will be ending up at the maybe the apex or in the furcation area of the molars. In primary periodontal lesion, it will go on the lateral aspect of the root. In primary endodontic and secondary periodontal lesions, the sinus tract mainly at the apex or furcation area. Definitely. In primary periodontal and secondary endodontically diseased tooth, the sinus tract mainly is at the lateral aspect of the root, and in true combined lesion, it is actually very difficult to trace, but we have to take maybe multiple radiographs. But if you are landing up when you are able to not recognize where this is going, sometimes in certain x-rays it is going at the middle third, or sometimes it is touching the lateral aspect, or sometimes it is going through the furcation, you should have something in mind that it could be a true combined lesions, and also the treatment will be required would be endodontically and periodontal treatment as well. Radiographs definitely will help us in looking at if there is any periapical radiolucency, if there is any lateral radiolucency connected with the root, if there is any old restorative material, or if there is any incomplete root canal treatment, or there is any bone loss that can be seen. There is generalized bone loss. The bone loss is from the crestal to the apical third, or how is the type of bone loss, horizontal or vertical. Definitely radiographs are helping us in judging how is the lesion. And crack tooth testing, definitely we all know it is painful response on chewing or when you release the bite. Obviously primary endodontic lesions will have painful response, periodontal will not have any response. Wherever primary endo and secondary perio, or primary perio or secondary endo is primarily perio is involved, there will be no symptoms. Whenever there is primary endo involved, there will be painful responses involved. Now, this is a little chart which will help us in how do you differentiate between pulpal and periodontal disease. This is what is very important, because I keep fighting with one of our periodontists that no, this is pulpal disease, no, this is periodontal disease. But this needs to be clear when and how will you call it a periodontal abscess, or when will you call it as a periapical abscess. So in pulpal conditions, the cause is usually pulp infection, which we all know. There will be cavity involved, there will be old restorative material or any trauma. With periodontium, there won't be anything. Maybe the vitality test will be negative or something, and there will be periodontal infection. Maybe plaque, calculus, marginal gingivitis will give us a hint. Vitality, pulpal tissue is usually non-vital. Periodontal would be vital. Restorative, we have discussed earlier. Plaque, calculus, we have discussed earlier. Inflammation, maybe if it is acute case, then definitely will have a good pain. In periodontium, it is a chronic condition. Pockets in pulpal condition is usually single and narrow. Periodontal is multiple and wide. pH value, obviously we're not going to judge there, but if it is often acid and usually alkaline periodontal. Trauma is usually primary or secondary in cases of pulpal, while it is a contributing factor in periodontal tissues. Maybe trauma from occlusion or any other trauma. And there are microbial organisms, very few in pulpal and too many in periodontium. Now, what is the differences between pulpal and periapical and periodontal abscess? The very, we'll see all of them one by one, and then we'll have the last one is very important one, that is very little important, or very important maybe in my case, when you're treating the tooth. So periodontal abscess will have a periodontal pocket. Periapical abscess will have caries or fracture. will be able to see what is the cause. Periodontal abscess may occur after periodontal treatment because we keep cleaning the calculus, or sometimes we are too vigorous or too aggressive during the scaling treatment or root planing treatment. That will definitely cause the exposure of dentinal tubules and will or accessory canals, and will lead to the exchange of inflammation between pulpal and periapical or periodontal tissues. In periapical abscess, it may occur after endodontic or restorative treatment. In periodontal abscess, usually tooth is vital. We can have a cold test or heat test or electric pulp testing. It is usually non-vital in periapical abscess, saving on your local anesthesia. Pain is usually dull and localized. Pain is usually severe and difficult to localize in periapical abscess. Swelling is present on the lateral surface of root, usually without fistulous tract, as abscess usually drains from pocket opening. And in periapical abscess, it is usually present in the apical portion of the tooth, which drains by the formation of fistulous tract. Maybe you can call it as a sinus tract. Periodontal abscess is usually tender on lateral percussion. Periapical is usually on vertical. Periodontal abscess is usually not visible on radiographs because maybe we see a good swelling. And in periapical abscess, we have a good radiolucency periapically. Now here is a photograph that is describing this point, that from where this fistulous tract is coming. So from the gingival margin, when you apply a pressure against the gravity, if it is a mandibular arch, and if it is upper, then you press it from the gums to the tooth. And periapical abscess, it is usually in the apical area, maybe on the attached gingiva. I hope I am making you guys clear. Now coming to these two basic questions, is periodontal disease the cause of pulp necrosis? We keep fighting over it, maybe not in the colleges, but later, yes, definitely. And can a pulpless tooth be saved or can be a cause of periodontal disease? These are the two questions that keep coming. They keep asking every time. There are times that I have done a very good root canal treatment and the clinician hasn't given a very proper crown, or maybe clinician has given a proper crown. It looks amazing. The margins are fitting very nicely, but the cement could not be removed with the floss while there was a cementation happening. And it had a trigger, and then it keeps giving us a periodontal defect, and then ultimately leading to the micro leakage or failure of the apical area or the cementum area, and then causing the pulp necrosis or the failure of root canal treatment. So all of this needs to be discussed. We'll discuss in two ways. What are the effects of pulpal disease on the periodontium, and what are the effects of periodontium on the pulpal disease? Since we all know there are dentinal tubules, accessory canals, and there are too many factors that we have seen already, which is responsible for making a communication between pulpal and periodontal tissues. So there is definitely a connectivity between pulp and periodontium, and there is definitely an effect. So we'll just see. In early cases, when there is very little inflammatory changes in the pulp, there is very little effect or very lesser effect will be seen in the periodontium that can be recurred back. But when the inflammation has exceeded too much, when the pulp has become necrotic, it will produce inflammatory responses, it will produce inflammatory cell, and there will be a process into the periodontal tissue, which it will show as in on radiograph, maybe in the form of lesion, or maybe in the form of apical periodontal ligament thickening, or lamina dura. Also, the nature and extent of periodontal destruction will depend on violence of pathogen in the canal system, duration of the disease, definitely if it is acute or chronic, and defense mechanism of the host. Definitely, it is very important. Now, there are two studies which are in the support of it. So one of them is by Jensen et al. In 1998. It said that potential effect of tooth with necrotic pulp has been described as a risk factor in the initiation and progression of periodontal diseases. In short, it is just describing a necrotic pulp will be acting as a risk factor for periodontal diseases that we all know. Any tissue, if it is lying dead in the body, will not only cause damage to the surrounding or nearby tissues, but will also affect the survivability of other tissues as well. And Dime et al. In 2002 reported that all the tissues of the periodontium had a potential of regeneration regardless of the status of pulp. That is, even if a proper endodontic treatment has been done, periodontal disease of pulpal origin should heal. There was a contradicting study by Sanders et al. In 1983 that reported that after the use of an allograft, 65% of the teeth that did not have root canal treatment showed complete or greater than 50% of bone fill in periodontal osseous defects, while only 33% of teeth which had root canal treatment prior to the periodontal surgical procedure had complete or greater than 50% bone fill. So it said that it doesn't matter if you have done root canal, if you have not done root canal, but we have seen the cases where 65% of teeth heal even if root canal treatment wasn't done. So that is how it wasn't connected. Now, coming to influence of endodontic procedures on the periodontium, we have seen influence of pulpal disease on the periodontium. Now, what all is the endodontic procedure doing on the periodontium? Of course, aggressive removal of periodontal ligament and underlying cementum during interim endodontic therapy will have adverse healing. Do not touch the periodontium, it will heal very nicely. Precautions should be taken when periodontal therapy is being done or is to be followed by endodontic treatment. We should try being as gentle as possible, induce less mechanical trauma, use more biocompatible sealers. Nowadays, too many good sealers are coming. Not promoting any sealer, but a sealer here, but there are too many sealers coming nowadays, which are on a way very nicely, which have good properties as compared to the sealers that were coming before or which were coming traditionally. Now coming to what is the effect of periodontitis on the pulp. Of course, we have seen there is communication that will again, it is a two-way communication. You have effect from the pulp on the periodontium, you have effect from the periodontium to the pulp. Now, this periodontitis will have an atrophic and other degenerative changes like fibrosis will be seen, or there will be calcification or narrowing of canal or sclerosis or inflammation or resorption of cells, which will lead to disruption of blood flow through the lateral canals and will have the localized areas of coagulation necrosis in the pulp. Will have a coagulation necrosis in the pulp. There are again 3 studies to justify this. Selzer et al. In 1978 found inflammatory alterations and localized pulp necrosis adjacent to lateral canals in roots exposed by periodontal diseases. Sometimes we do etching onto the root surfaces. It doesn't give a very good effect onto the cementum, or if there is a very thin layer of cementum, or if there is anyway a denudation of cementum present and we are being aggressive, then of course it will not only have a poor periodontal therapy, but also it will affect the tooth endodontically, or the pulp will be affected. And Cohen in 2002 have suggested that there will be periodontal diseases do cause pulp necrosis. Periodontal disease is a direct cause of pulpal atrophy and necrosis. Rathod et al. In 2014 said severe chronic periodontitis can affect dental pulp. Definitely, if there is a chronic periodontitis, we believe that dentinal tubules are just not sitting idly. The fluid, the odontoblastic processes, they do cause the damage. There was a contradicting study by Kirkham in 1975, and he studied 100 periodontally involved teeth and found 2% had lateral canals in the periodontal pocket. So he said it's just 2% lateral canals in the periodontal pocket, not that all of the periodontium will have, or periodontal diseases will affect the pulp of the tooth. Tegger and Smuckler in 1979, they removed roots from the molars, which were extensively involved with periodontal diseases in which root amputation was necessary. And they again showed that pulps of these diseases had no inflammatory changes. However, these studies are not only old, but these are the treatment modalities that are used nowadays as well. Mazur and Messler in 2009 found no relationship of periodontal disease as a causative factor in pulpal diseases. Now coming to effect of periodontal procedures on the pulp. We have seen already, we have discussed already, scaling and root planing. If it is being done aggressively, it just not removes the bacterial plaque and calculus. However, if it is done in proper way, definitely can also remove cementum and superficial part of dentine, thereby exposing dentinal tubules to the oral environment. Acid etching is by citric acid removes the smear layer, which is a very important pulp protective, we all know. And application of citric acid may have a detrimental effect on the dental pulp. If it is if during any procedure, if it is very close to the pulp, if there is a very thin layer of dentine and we are applying acid, we are etching it with acid and we are doing it for a longer period of time or with not very good concentration, then definitely the pulp is going to get affected. Now we'll discuss one by one what all are. We have seen already primary endodontic lesions as in the classification, primary perio, primary endo with secondary perio. We'll just keep seeing them one by one. What all are the features in all of them separately? Primary endodontic lesion will be primary endo. We all know caries or restorations or any treatment required done with the tooth will be involved. So the causes will be caries, large restoration, traumatic injuries, pulp capping, poor root canal treatment, under obturation, over obturation, too many things. What all will be the characteristics? How will you justify that it's an endodontic lesion? So the characteristic features we'll see, we have discussed. We'll go for visual examination, we'll go for palpation, we'll go for probing depth, we'll go for sinus tracing, and then we'll continue. So tooth mobility in primary endodontic lesion should not be much, but if it is a vertical fracture or any other cause, then maybe tooth mobility will be high. Narrow pockets will be present if checked, or periodontal pockets will be present. Swelling may not be. It will be so to it will be tender on percussion, basically on vertical percussion. And characteristic clinical feature will be sinus tract could be present, could not be present. But in the cases where we are justifying them with the primary endoperio lesions, sinus tract is usually present. It will have a localized bone loss because there will be a pocket present definitely. Pulpal test, since the pulp has already been necrosed, so it is usually negative. It is usually rapid onset and has sinus tract that we have seen. Treatment will be primarily endodontic treatment will only be required and it will have a very good prognosis. Here is the radiographs. Here are the radiographs taken from certain books that are showing that because of not rightly done root canal treatment, because of not the rightly done root canal treatment, the patient or the tooth had radiographic signs showing with not very good lesion was present. And when a proper treatment was done, then it migrated and it healed the bone. A very good thing with the bone is that it heals. A very bad thing with the tooth is that once it is destroyed, it is destroyed. So we should try to save the tooth as much as possible. Now coming to primary endodontic lesions with secondary periodontal lesions, the characteristic clinical features will be long-standing pulpal pathosis. Superimposition of plaque or calculus will be present because it is primary endodontic with secondary perio. Generalized periodontal disease should be present. Pulpal test will be negative. Significant periodontal inflammation will be present. Angular defects will be present when seen in the OPG. Conventional root canal therapy and periodontal treatment will be helpful in this case. Anywhere perio endo is involved, both of the therapies will be required, but it will be decisive in nature if you know whether it is primary endo or primary perio, that we should be focusing on which therapy first. Here is the premolar, which shows a premolar with not so good filling or very close filling to the nerves. It initiated some bone defect. Ultimately, a root canal treatment was done and it healed the bone. Now with the primary periodontal lesions, the characteristic clinical features will be, because it is just perio, no endo, so teeth should be vital. The pulp vitality should give a positive result. It will have generalized bone loss, calculus and plaque will be present, soft tissue inflammation, broad-based pocket. All of the features that we see for a periodontal infections will be present. Possible occlusal trauma from occlusion could be present. Pulpal test will be positive. Radiographs will definitely help us. The bony defects and periodontal probing, generalized probing depth or pocket be present there. Treatment will be definitely periodontal treatment. Now, this is a radiograph. This is a photograph which is showing us that the tooth had lesion without any involvement of the pulp, and ultimately, in this case, the tooth showed positive pulp testing. However, the prognosis wasn't very good, so the tooth was removed. Now, coming to primary periodontal lesions with secondary pulpal lesions. Primary perio with secondary pulpal will have a characteristic clinical features where you'll have a deep periodontal pockets, maybe the bone loss more than 6 to 8 mm, history of extensive periodontal procedures, clinical root planning or scaling or flap or any other procedures. Irreversible pulpal pathosis will be present. Pain would be too much. Teeth has definitely large restorations if at all it is present, or if at all there is difference in bite or difference in the masticatory processes will be present. Test will be disease progression, periodontal probing, and pain be present. That all has to be what is the type of pain, dull or aching or sharp or pricking, or whenever it is coming at night, or how is the pain coming, when it is coming, from what you are feeling the pain should be clinically evaluated with the clinical history. Treatment will be endodontic treatment and periodontal treatment, since it is a combine of both the diseases, and it will depend on periodontal therapy moreover. In true combined lesions, now it is a true combined lesions, so etiological factors of both the conditions, treatment of both the conditions, differential diagnosis, will see that it might resemble vertical root fracture, maybe a J-shaped lesion or bone loss around the root will be present. Perforation might not be present. It will have clinical features same as vertical root fractures or perforations or resorption. Vitality test will be negative. Periodontal probing will be present at numerous sites. Treatment will be endo and perio both simultaneously. Now this is a radiograph. This is a photographs and radiographs showing combined lesions. The tooth had radiographic lesion. There was a periapical bone loss. There was a bone loss in between the roots, or intra-bony bone loss was present. A surgery was performed. There was root apicectomy was done, or root amputation was done. And then after a period of 6 months or 3 years, this is a radiograph, the last one photo, which is showing after 3 years follow-up with the same tooth. Now, concomitant pulpal and periodontal lesions. This is such that both disease states exist with no evidence that either has influenced the other. The pulpal disease is started by itself, the periodontal disease is started by itself, and both of them are progressing at their own rates, at their own pace. They are happy in their own world. So there is no that they are connected by any means, or there is no proof that they are connected. Also, with this tooth, with this diseases, it becomes little difficult for us to diagnose if it is a combined lesion or it is a concomitant pulpal and periodontal lesion, or if it is a primary perio, primary endo, secondary perio lesions. Treatment, both the entities will be treated separately, and it will depend on the removal of the causes as well. The cause should be removed in all of the cases. Now, coming to a very important part, since we have been discussing about what all are the lesions and how will you diagnose it and how will you do it, but clinically we all know what is important is just the treatment. So coming to the important part, that is we have had too much of suspense for how will you treat. So there is this chart that I have always been sharing with too many people, which is in short, we don't have to go for, we have seen already where an endo is required, where a perio is required, but how will you proceed when any of the treatment is not working, and how will you determine the prognosis of the treatment. So whenever you have endoperio lesions, you have recognized that there is a radiograph present. You see there is pain, you see there is periapical abscess or periodontal abscess, you see there is a radiograph that will showing periodontium loss, or you have diagnosed that it is an endoperio lesions. So how will you proceed? If it is a primary endodontic lesions, we know that we have to go for root canal therapy or endodontic therapy. If it is a primary periodontal lesions, you have to perform just a periodontal therapy. If it's a combined lesion, then we start with primary, and if it's a combined lesion, then how do we proceed? So primary endodontic and secondary periodontal lesions. So primary endodontic will require first endodontic treatment. And a basic hygiene procedure such as scaling and root planing will anytime be the later part, but just a basic hygiene procedure. Also, in such cases, we cannot do a single sitting root canal treatment. It is always advisable to go for multiple sittings root canal treatment with just not the saline irrigation or hypo irrigation, but also some other irrigants can also be used, such as chlorhexidine or metrogen, and there are not many different irrigants coming. If it is primary endo with secondary periodontal lesion is due to iatrogenic damage, such as perforations or fractures or not very good root canal treatment or ledge or zipping, then you have to seal the perforation or you have to repair the cause with too many advanced materials coming these days. MTA biodentin are no less, and there are other materials. If it is a root fracture, you should know how to manage the root fracture. If it is a vertical root fracture, we should know how to manage the root fracture. Then after treating it with endodontic therapy, and just when you have performed a basic hygiene procedure, just do not forget about the tooth. It is always good to see your healing cases. So you should have evaluation after 2 to 3 months. And then also, if it is not healing, then this should be informed to the patient that you might have to do one extra periodontal therapy as well. If it's a combined lesion and you see it is a primary perio or secondary endo lesions or true combined lesions, then of course regenerative therapy with the GTR or bone membrane or other such procedures will be required. But primary to surgery, periodontal therapy or adjacent periodontal therapy or root canal treatment will be should be done. Then again reevaluate after 2 to 3 months. If there is a periapical resolution, then it's okay. But if there is no periapical resolution and the tooth has hopeless prognosis, then just remove the tooth. Sorry to say, but just remove the tooth. And if there are certain procedures like root resection or bicuspidization, I'm sorry, or hemisection can be performed, then all of those treatment options should be discussed with the patients. If this teeth after periapical resolution have great mobility, but it is lesser than grade 1 mobility, or if there is no mobility, and there is no mobility, then we should be happy. But if there is a mobility that is more than grade 1 mobility but lesser than grade 2 mobility, we should just not leave the tooth as it is, saying that it will heal by its own. We should try to splint the tooth, because sometimes the mobility might increase, and sometimes this will not help, or this will not allow the attachment apparatus um, to regenerate or to recover back. If after splinting, if the periodontal pocket is less than 4 mm, then non-surgical maintenance can be done. If it is more than 4 mm and less than 6 mm, then it might require osseous surgery. And if it is more than 6 mm, then definitely a GTR treatment will be required. All of the treatment, any treatment, even if it is just endo, even if it is just perio, if it is a combined endo-perio treatment, all of the treatments should have a follow-up so that we know that how our treatment is resulting back. This is one more chart that is showing us how will you treat an isolated endoperio lesions. Nothing, just a basic thing, that a primary endo lesion is usually isolated, localized, and it has narrow pocket. We should check for endodontic status. If a root treatment can be done, then we should repair the tooth, or we should go for root canal treatment in a very good, in a proper way. It should not be over prepared or under prepared or overfilled or underfilled, or no ledge or no zipping or no perforation should be present. If preparation is all adequate, if root canal treatment is feasible, and if the preparation is all fine, then just normal oral hygiene instructions should be given. If it is not adequate, then it should be corrected, and then we should go for debridement and oral hygiene instructions. If it has resolved, then it is okay. If it has not resolved, then we should go for first stage cleaning of endo, and then cleaning and chipping of canals, followed by intracanal medicaments such as triple antibiotic paste or calcium hydroxide or any other medicine, if at all it is required. If it is healed well, then good thing. If not, then we should look for other cases or other possible causes which are delaying the healing procedure, or which is not letting the tooth live. And if there is any procedure which is not letting the tooth live, we should try to we should give a chance to the tooth. Also, we should not try to take away anybody's life. So is the tooth's life there? Then final treatment option would be, if definitely if none of them are surviving, then final treatment option would be to extract or resect or hemisect the tooth. Even a hemisectioning is a good option if a patient is willing and if the clinician is that confident about the procedure. If not, then should try to refer the case. So this is how you manage the cases. There is nothing that we discuss about how do you perform a root canal therapy, or how do you perform a periodontal therapy. That is all the way a separate topic that should be discussed. Now, these are very small points that are to be given as a conclusion or as in a take-home message. One is a perioendo lesion can have a varied pathogenesis, which ranges from quite simple to relatively complex one. To make a correct diagnosis, the clinician should have a thorough understanding and scientific knowledge of these lesions, definitely. If you do not understand, you won't be able to diagnose, you won't be able to treat the tooth or the patient, and then you will have sleepless nights otherwise. Despite the segmentation of dentistry into the various areas of specialization, the clinician needs to perform restorative, endodontic, or periodontal therapy either singly or in combination. That is, you perform it with a group or you perform it singly, but you have to perform if you have a patient in the setup. Therefore, to achieve the best outcome for these lesions, a multidisciplinary approach should be involved. There should be no shame in, or there should be no hesitation in if 2 or 3 of the fields are involved, and there should be no hesitation in accepting the fact that this tooth needs a group of doctors or group of clinicians to be treated very well. So here I resume, and I hope whatever little knowledge I had, I have shared it with you. If there are any questions, they can proceed well. Thank you. These are my references.
Thank you so much, Dr. Shukla, for that very insightful and informative presentation. We have a couple of questions that we would now like to pose before you. The first question that we would now like to ask is, what are the factors to be considered to identify the primary cause of endoperio lesions?
That is very important and should not be skipped because it is not important to diagnose or to manage. Also, we have discussed in our in the topic in the presentation before, etiological factors such as bacteria, fungi, and viruses, as well as there would be contributing factors such as trauma or root resorption that will help in the progress of the diseases, or if there is any developmental defect, will definitely be a part or should be considered if there that this could be a perioendo lesion, because there are contributing and etiological factors present there.
Thank you for that response, Dr. Shukla. The second question that we have for you today is, how do you manage endoperio lesions?
Type of an endoperio lesion it is. So, and also what is the cause that is causing these lesions, and so then we'll be able to, usually in endoperio lesions, endodontic treatment is one that is very important, and usually it is these lesions heal with endodontic treatment, but wherever in 20% cases, wherever a periodontal treatment is required, a periodontal help is required, it should be asked for.
The third and the final question that we would now like to ask you is, do you treat endo or do you treat the perio lesion first?
Usually endodontic treatment is preceded by periodontal treatment, but wherever a periodontal treatment is required, it should be done and should not be skipped. Usually we have seen during the years of practices, we have seen a true combined lesion usually also does not require periodontal treatment. It shows the sign of healing, but wherever it is required, it should be required, so that if a tooth is living, it should live very happily. Also that if it will survive for 2 years, then if you perform a periodontal therapy, it will survive for a lot more years. So endodontic therapy should be preceded by periodontal, but should not be skipped.
Thank you so much, Dr. Shukla, for those very insightful and informative responses. We are sure our audiences must have learned a great deal from this presentation about the management of endoperio lesions. To all our viewers, thank you so much for being such an active audience and for your participation in this webinar. We hope to bring you many more such clinically relevant topics under dentistry in the coming weeks. Please take care.